I'm Randy Reed, Executive Director of the National Lighting Bureau, and welcome to our series, Let's Talk About Light and Health. Today's session is entitled Equal Lights, Projects Focused on Health Equity, and I am joined by Dr. Carol Horowitz, Professor of Medicine and Dean for Gender Equity at the Icahn School of Medicine at Mount Sinai, and she's also the co-founder and director of Mount Sinai's Institute for Health Equity Research. Dr. Horowitz, welcome.
Hey, it's great to be here. Thanks for inviting me.
Well, thank you for joining us. And the first question, tell our audience, what does health equity mean?
It's a really good question. So the goal of health equity is to make sure that every single human being has an opportunity to be as healthy as they possibly can be. So sounds easy, but it's easier said than done, because to have health equity means that we need to remove the obstacles to good health. And a lot of those obstacles are things like poverty and discrimination and their consequences. For example, if you don't have access to good jobs, good education, good housing, healthcare, and healthy and safe environments, you're much less likely to be healthy.
You're not going to be able to fix poverty. You're not going to be able to fix all these issues. So how do you have health equity if you can't fix those issues?
I'm going to take slight issue with you saying that we can't fix these things, because we must fix these things. You know, historically, I'm a primary care doctor, and the view of me maybe 20, 30 years ago is I go into my office, I see my patients one-on-one, they go home, I go home. But that meant that I kept seeing the same problems again and again and again, the same kind of sicknesses, the same kind of things that are impacting how long we live, how well we live, the kind of illnesses we have. And we started realizing that we can't just narrowly focus on healthcare. We have to start focusing on the things that make people sick and therefore can help people be well. So that includes things like, how do we improve wealth in societies? How we've done projects, for example, if you have diabetes and you're food insecure, you can't get the healthy foods you need to eat healthier. We now have programs to bring low-cost, fresh, healthy foods to the people who need them the most. If we don't pay attention to these environmental barriers and address them, we'll be right now where we are right now in 20 years, and that's not okay.
How long has Mount Sinai had an Institute of Health Equity Research?
Mount Sinai and others around the country and around the world have been trying to do things to address health disparities and inequities for a very long time. But we are a startup. Our institute is only 2 years old.
Congratulations.
Thank
you. Are
you.
the co-founder. You are the co-founder, correct?
Yes.
Can you explain to our audience some of the projects that the Institute is working on?
Yeah, thank you for giving us a chance. We're very proud of the work we've already begun to do that's built on the shoulders of the people, the hardworking people who form our institute and people who have guided us through the years of our careers. We have 4 major areas in the Institute. One is looking at big data. So how do we use big data to uncover what the challenges are with the policies that we have, problems in our environment, problems, changes in people's genes, all the different things that come together to influence health. For example, research has shown that there are genes that actually impact whether or not you get kidney failure. And those genes exclusively exist in people who have African ancestry, because they happened in Africa. There were gene changes to keep people from dying from sleeping sickness, which is only in Africa. We used big data and said, well, is it only genes that make a difference? And you know what we found? We found that Black people, because of residential segregation and policies, are more likely to live in polluted areas. And air pollution is bad for your kidneys. So if you put together genes and your environment, your risk of kidney failure goes way, way up. So we're using big data to uncover what the stubborn problems are. So that's one of our cores. Another of our cores is an engagement core, community engagement core. I am a white professional who drives her hybrid vehicle out to the suburbs every day at the end of my day of work. Is it really appropriate for me to be developing these solutions on my own? Of course not. So people like me partner with people from the communities that are so disproportionately and unjustly impacted by health inequities to make lasting solutions that are going to work in their community. We also have a core to look at healthcare inequities. How can we make healthcare something that provides equity and not causes equity? And finally, we have a training core to develop the next people in our healthcare workforce that are diverse and focus on diversity and equity.
Okay, so four things, that is a lot. The first one you mentioned just really struck me when you talk about the genes, because
Mhm.
I guess in days of old, researchers say, oh, it's part of their genes, nothing can be done, and we would just forget about it. But with big data, you're realizing that the environment and the pollution plays just as big of a role. So I do understand how the big data can really make a difference. And I guess that's what makes your institute kind of unique, because you're looking at that whole picture.
We call it intersectionality. It's the way things come together. Almost nothing is 100% in your genes. Now, if it is, there are gene therapies and other things that we're beginning to be able to do, which are really important. So this gene change I'm talking about with kidney failure, there are now new gene therapies that are just starting to be tried. We don't know if they work yet, but we can figure out other factors. And what we found, for example, is when we told patients that they had this gene, do you know what they did? They took their blood pressure medicines more, they changed their behaviors, and their blood pressure came down. So we never want to look at poverty or genes or anything as, there's nothing we can do. There's always something we can do. And that's what our institute is about. What can we do?
Okay, great point. I understand that. So our audience is concerned about a lot of things, but we're very interested in light. Can
Mhm.
you talk to us a little bit about light and health equity?
Yeah, we are really lucky because a few doors down from me are the folks from the Center of Lighting and Health, run by Mariana Figuera, her partner Mark Ray, and others. And they have been really pushing us. And together we've been thinking a lot about lighting and equity. And when I first was learning from them, my first thought is, well, what makes people have a good night's sleep? Think about why you have a good night's sleep, right? So you're relaxed, you don't have a million things you're worried about. You're in a comfortable place, a quiet place, a dark place, right? We know if we don't sleep well, we don't do anything well, right? Exhausted people are not functioning people and not happy people. So what does that have to do with inequity? Think about it. If you're in a neighborhood and people who are non-white, because of these structural racism issues we're all learning about, are more likely to live in lower income and less safe neighborhoods. So what happens in these neighborhoods? We crank up the light in the outside to we think it's going to be safe for that. There's light pollution. There are cheap lights inside, outside of houses, which cause what we call glare bombs. They never vary in intensity. So your light doesn't get dimmer when you go to bed. Think about what would happen if it didn't get dark, right? There's less natural light because you're in apartments that don't really have windows, or you're looking out onto a little alley. Therefore, you don't have that circadian rhythm that regulates sleep-wake. You have more stress because you're lower income. You're in a more distressed neighborhood. You have more mistreatment. You have jobs where you don't have control over when you sleep because you have a day shift and night shift. And you have less access to resources. So if you think about it, there is a perfect storm that has to do with light and inequity that is impacting people and causing inequity in sleep, which then has this cascade of issues that lead to people's poor health.
Sure. Well, can you share some of the research projects that you are working on right now?
Yes, I also want to share another reason we care about lighting and equity beside this type of lighting is that if you're lower income, you have cheaper lighting, which is not as good for you. Older people, so older non-white people have this cheaper light, and older people you probably know are more sensitive to glare. So it actually affects your ability to see if you don't have good light. And some of us can afford better light than others. And finally, think about stairs. If your stairwells are not well lit, it's less safe. Someone can attack you in a stairwell. And also, people fall down. Again, bad light, bad glare, people can't see, they fall down. So not only sleep, but also basic issues around safety and your ability to see have a lot to do with the quality of our lighting, who gets access to better light than who else.
Well, I would just add on the stairwell thing, it's not just low light levels or bad light levels. It can be too much light levels.
Yes.
At night, they don't want to turn the light on because it is this huge glare bomb. So they'll just walk down the steps, dark, and feel their way. And that's when accidents happen. Okay, Dr. Figueroa was explaining to me about the oxygen sensors that happened a lot during COVID. Can you tell our audience a little bit about that and any research that you've done?
Yeah, this is an amazing thing. So this has been a problem for a while, but like a lot of things, COVID is a tragedy, and the people who've lost their lives to COVID is a tragedy. The only thing I can say that's at all positive about it is it forced us to look at some inequities and some real problems that people hadn't given enough attention to before. So when people have COVID, one of the biggest things COVID impacts is the lungs, right? People have difficulty breathing, okay? So what we would do is we'd measure people's oxygen levels. If your oxygen levels were low enough, it would mean we would have cutoffs. And those cutoffs would determine who got treatments, who got oxygen, and who got admitted to the hospital. In some ways, it determined how intensive your therapy is and whether or not you would live. Well, what people found out is that these machines, these little pulse oximeters that go on people's fingers that we usually use, that are cheap and easy to use to see how much oxygen people have, are flawed among Black and darker skinned people. And this may have actually contributed to deaths from COVID. Because these meters that we developed, these oximeters, were piloted on very small groups of people. And guess what? Almost all those people were light skinned, were white. So what we didn't realize is the technology did not read well in darker skinned people. They got falsely elevated readings. So if I have light skin and I went in, my oxygen saturation might be viewed as low and they'd say, oh, you need treatment, you need oxygen, let's get you right in. If I was darker skinned, I might have a false reading that said, no, you're okay, go home. This is a life or death problem with technology. It's just started since COVID to get really big attention to what we can do about it.
That is unbelievable. And
yeah,
hopefully today those oxygen sensors have been fixed.
So this is how things go with equity. First, we have to think about the problem. Right. Then we need to document the problem. Then we need to solve the problem. The problem has now been documented, and it's been brought by Mariana Figueroa, Mark Ray, and others to the Food and Drug Administration and to others to say, we have a problem, we need to do something about it. We now have a grant led by Mariana and Mark and our folks from IHER to actually develop simpler, lower cost pulse oximeter machines to replace the current biased ones. So right as we speak, Mark and his team are building these new machines. And over the next year or so, the teams will be testing them and seeing if we can have bias-free readings.
So I want to understand, they are actually building machines. They've designed and they're building the machines that will be used to measure oxygen sensors with light.
Right. So they found some simple, So they found some simple technologies that they believe they've identified the reason for these biases and why we're getting poor readings in darker skinned people. And they have fixes to these machines to add new technology that they think will be able to make the difference.
But to be clear, today, if a African-American goes into an emergency room and they are measuring their oxygen level using the pulse oximeter, they could today be getting flawed numbers. Is that correct?
Some people will today be getting flawed numbers. So for now, there are now being kind of warnings sent out, that this might not be accurate. Unfortunately, right now, the only replacement we have for this is invasive technology. It's called the blood gas. So you put a needle in someone's artery and you measure it. That's very painful and it can be risky. So right now, what we're saying is beware of this. If it's really one of these life-death decisions, whether someone's going to be admitted to the hospital or get a life-saving therapy, you might need to do something more invasive. Otherwise, you need to take these readings, and some people with a grain of salt, and go as fast as we can with experts like the folks in the Center for Lighting and Health to fix the problem. Okay. And it's not just for COVID. When people have emphysema or COPD, their oxygen levels could go low, and it determines who's on home oxygen. Might determine who gets disability payments because of who's considered disabled based on their oxygen. So there's a whole area. And this is what we're finding, that when we look at things that we thought were tried and true, there are biases and we need to address them.
Okay, well, Dr. Horowitz, is there anything I have not asked you that I should, that you'd like to share with our audience?
I'd like to share that systems are created to get the results they get. We have bias systems, we have problem systems, we have biased machines because of the system created to get them, where we tested things on all white people, where we didn't get diverse perspectives, where we didn't think, I live in a house in the suburbs. Was I really thinking about what it's like to live in a neighborhood where there's lights and sirens going on all night? So what I hope for your audience of very talented, creative people is that you stop and you yourselves and your teams are challenged to look at the things that you do and say, do these benefit everyone equally? And if not, how can I fix that? And reach out to folks like Marianne and Mark, reach out to folks like us and say, we need partners to help us understand what our problems are and fix them, because that's the way we're going to make a much healthier tomorrow than we have today.
Well, Dr. Horowitz, this is excellent. And thank you for the good work that you're doing.
Thank you.
It is really incredible and wonderful what you're doing. Please stick around, and we're now going to open the floor for questions. And Dr. Horowitz, thank you so much for that very informative discussion. We want to thank our sponsor, New Star Lighting. The floor is now open for questions. Please use the Q&A button to submit your questions. Our next session will be Monday, 19 December, same time. Not your typical design, circadian effective lighting. And our guest speaker will be none other than Allison Thayer. We have saved the best for last. And you can sign up at lightandhealth.eventbrite.com. Allison is our producer also. And before I turn over to you, Allison, there's one question that I failed to ask Dr. Horowitz. And Dr. Horowitz, can you share any future research that is upcoming that you're hoping to work on?
Very good question. Thank you for asking. So some of the research we're looking into is, especially now that the Center of Lighting and Health has a footprint in New York City, not only upstate New York, but also New York City, is we're looking very carefully at our neighbors in New York City. So we have a lot of subsidized housing, low-income housing complexes all around us where the people living them struggle with some of the issues we're talking about. So we really want to start working with folks in these buildings to understand how lighting impacts their everyday life. Is it causing problems for their children to be able to learn, to get good night's sleep? Is it impacting stress? Is it impacting mental health? And then we want to work in partnership, and this again is led by Mariana and her team. We want to work in partnership with those communities to develop lighting solutions that are low cost and effective and meet their needs.
Okay, that sounds very exciting. Okay, Allison Thayer is our producer, and Allison, I will turn it over to you.
Awesome. Thank you, Randy. We'd love to hear from our audience, so please ask your questions. So Carol, you mentioned a lot of great things in your interview. A couple of things that stuck out to me. You said focus on things that make people sick, things that we can maybe preemptively avoid. So something like daily solutions, like people sleeping better, because when you're not sleeping, a lot of things can happen, things like lower immunity, just, your day-to-day things. And you had mentioned too that people took more medicines when they knew that that it could really help them in these ways. Do you imagine things like teaching people to sleep better? How do you see this kind of working in terms of, in your practice and things that we can do as a lighting industry to teach people?
Well, I'll say for me as a primary care doc, where my colleagues and I just see so many people have such problems with sleep and exhaustion. First of all, people don't realize the technology is out there. Probably everyone that's listening to this knows what flux is, and that when you're using your screens, you should be changing the lighting at night. A lot of people don't know that, and it's free. So there's low cost solutions out there people don't use. People don't recognize how light pollution can impact them, and whether that's a blind that's inexpensive, something to close up the light from the outside, whether it's shutting off your TV, shutting down your computer, those things. When Mariana and her team first came to our department, I walked into their office and their office was so bright. And I'm like, wow, this makes such a big difference. Then like, yes, because during the day it should be really light. And during the night, it should be really dark. So not only do we have a problem with too much light at night, we don't have enough light during the day. And they gave me a very inexpensive lamp and light bulb that I use in my office every day. There are technologies out there. And I think industries need to understand there are things out there that are already helping people that people are unaware of and don't have access to. So it's not only about uncovering problems, it's also uncovering solutions.
So a question we had pop up. So what is being done to reach out and educate people who are in this disadvantaged population so they can advocate for themselves?
I think that what's being done is in a few different ways. I am not a lighting professional. So I know a lot of us who are clinicians are working with our patients when, more in more recent times, maybe in the last 5 years, we start to talk more to patients who are having problems with sleep and stress about lighting. And I think that needs to become more a part of weaving into regular primary care. So we view changes in light as changes in the solution. Mariana and Dr. Figueroa and her team have done amazing work looking at medical errors caused by poor lighting. So there's all sorts of different ways lighting can impact health. But I think as an industry and as a lighting professional community, I'm hoping you will view it not only as something you could do, but something you must do, which is getting word out to people about how lighting and appropriate lighting can help make people healthier. I think it needs to come from you all even more than it comes from me, including, teaching clinicians like me what we should be doing.
Yeah, so I mean, there's a couple different sides. There's the clinical side, there's the individual side, and then kind of the industry. So it's a lot of people coming together to be able to put this together.
Like, I'm not sure that I've ever heard of conversations between a group of clinicians and a lot of, lighting industry experts. They might happen. I'm sure, I'm unaware of tons of things, but, what do we do better? How can we do better as a clinical community? Not in ways that are going to cost our patients a ton of money, but in ways that will make a really big difference in their lives.
So as a physician, do you think light will one day be used as a treatment?
I think it should be used as a treatment. I don't know enough about the area in general, but I think light as a treatment is what we're talking about when it comes to sleep and how to change the flux on your computer and how to change the lighting in your room and how to make it lighter during the day and darker at night. So I think it should be used as a treatment. I think there are other frontiers and where folks like Dr. Figueroa and her team are doing really excellent research, whether it comes to medical errors, whether it comes to improving cognition in people with memory problems, reducing falls. I think it should be a treatment. I think we need leaders like the ones that are sponsoring this to come forward and make sure that happens.
Yeah, and it's really learning how to apply it as well. Good lighting doesn't have to be expensive, but it has to be applied correctly, and people need to know how to use it. Having those bright days and knowing how to dim them at night, turn on flux, like you mentioned, on their computers, on their phones. So it really does come from having the access to it, but also knowing how to use it, which is always the struggle.
Exactly.
So how do you think we can help educate people on good, not necessarily cheap lighting? What do you need from the lighting industry to accomplish that?
Help me. If I want to have healthy lighting in my home that doesn't cost a fortune, what do I need? Do I need a bulb in my room? Do I need a bulb in every room? What kind of bulb do I need? What do I need to know? If there were simple guides, I would take the example of what people do in environmental health, where there's really simple guides and they're agnostic to what it is in the industry, but something like BPA-free bottles that are healthy or BPA-free lining in cans, whether it's what are safer household cleaners. There's well-worn other industries who've moved in and said, we have an industry consensus that these are things that are good for you. And I think if it's possible and people in industry could come together in this area and also say, these are things that are better or worse for you to have in these rooms in your home so you can sleep better or you can see better, I think those would be really, really helpful. And I know it's hard for industries to come together and all agree on one thing that might not benefit one versus another. We're all friends and we're also competitors, right? So we have to figure out a way to move forward with the best interests of the health of the population.
And I'll just jump in and add, you bring up a tremendous point. I think overall as an industry, we have been very weak at this, but we are getting better because now we do realize that the good of the overall humanity is more important than individual profits. And we are seeing companies come together. We're still working as an industry with the whole circadian stimulus and trying to find a methodology that we can all agree on. We still haven't, although we're close, we're still not there where we need to be. So you're absolutely right. Other industries have done it and come together, and the lighting industry needs to do that. And hopefully this video can help with that.
And I've repeated the analogy that, BPA-free water bottles.
Yeah.
Lots of people are making
You know,
lots of money on that. And it's not just one part of the industry, but when we saw that some things were better than others, the industry could all jump on and everybody did pretty well. And I hope that can be
sure.
a model.
But let's go one step further. Let's get rid of all the plastic water bottles to begin with. It bothers me so much when I see politicians who pretend to be so green and they go on TV and the first thing they've got is a water bottle, a plastic water bottle, as opposed to, you know, water from the tap or whatever. But there is plenty of room for improvement. Allison, before we wrap up, do you have any more questions that people have submitted yet?
I do have one more question. Yeah. Actually, another one just came in too. As a physician looking at patients from different cultures and locations, have you seen any standout differences in sleep, diabetes, depression, or other outcomes?
We do have massive health inequities in all these things, both in terms of race, ethnicity, and in terms of income of who gets sicknesses, who lives, and who dies. So, so when it comes to, I'm just reading back the question, there are really big differences in incidence and mortality from things like diabetes, things like obesity, things like depression, heart, cardiovascular disease. So we do see really, really big differences. So where we are at Mount Sinai, where the Center for Lighting and Health is, and where Institute for Health Equity Research is, we're right on the border of East Harlem, the Upper East Side. There's no wall breaking these two down. It's north of 96th Street and south of 96th Street in New York City. So you can readily cross from one neighborhood to the other. Upper East Side is one of the richest, whitest, healthiest neighborhoods in all of New York City. East Harlem is one of the poorest, sickest, and least white neighborhoods in New York City. And this and these differences are so blatant because of the way communities developed and the way that structural racism has segregated communities. One example, when you talk about diabetes, if you compare the two communities among people with diabetes, people in East Harlem have 16 times the amputation rate for diabetes than people in the Upper East Side. And that's not because people want to be sick. It's not because people want their legs amputated. It's not because people don't try. And these are the kind of things that we are developing solutions to take care of. And I think you folks in lighting can make some really great solutions as well.
And you had also mentioned the pulse oximeter as a device that has a bias. Are there other medical devices that have these bias that we know of that need a change?
There are a lot of biases in algorithms that we've been focusing on. You know, doctors make a lot of decisions based on algorithms of who has chronic kidney disease, who needs who can have a vaginal birth after cesarean section, you know, pulmonary function testing. There's a lot of these kind of testings where baked into them were algorithms where people of certain races and ethnicities got treated differently than others. And while some of them have some real reason to them, some of them are really biased. For example, the idea of interpreting pulmonary function tests based on race, believe it or not, and as horrifying as it is, came from slavery, where people wanted to view Black men as work beings differently than white people. So we have racism baked into these algorithms that make a difference. Some of them were done really naively and innocently and maybe with good intent, and some of them really weren't. And there's a lot of work around the country right now to undo these algorithms so they don't bias people who already are trying to survive other biases.
Okay, that is very sad. I was not aware of that. And the whole amputee thing, amputations about 16 times, is just unbelievably, terribly sad. So we sure commend you for the work that you're doing, Dr. Horowitz, and let's hope you can continue your research and continue to help inform people. We want to just remind everyone this will be available later this week on YouTube, and we will post that at the NLB website. And then our next session is Monday, 19 December at the same time, Not Your Typical Design, Circadian Effective Lighting. So Dr. Horowitz, thank you. And thank you, Allison, and thank you to our audience.
Thank you, everyone.
It's a pleasure.